Okay, I'm Lance Edmonds. I'm from Travis Air Force Base. I include this picture of my aircraft. I actually, the first time I was here at Wilford Hall or Lackland Air Force Base was in 1995 when I enlisted, actually this month, April. So it's 16 years since I enlisted. I was an aircraft mechanic on the A-10. I think that's why I enjoyed putting needles into people because of my love of mechanics. So when I drove on base, I was expecting people to yell at me because that's the last time I was here, was at basic training. This is at Travis. We're doing a hip cryo arthroplasty and a patient had breast mets. Basically, we drilled out the marrow of the bone with a hand drill and put a cryo probe inside in the femoral neck, cryobladed the lesion, and then cementoplasty the hip. Patient did great. We used ultrasound as a guidance method, kind of as an adjunct imaging modality. So I'm going to talk to you about ultrasound guided elbow interventions. First, we're going to talk about the elbow joint. There's a couple ways to access the elbow joint. You have an effusion, you want to access it one way. If you're doing an arthrogram, you want to access it another way. We're going to aspirate the elbow joint. We're going to talk about epicondylitis, both steroid injections, which are probably most common, and then prolotherapy, like PRP, which is one of the reasons why you're seeing this blossoming of ultrasound musculoskeletal courses is because of the advent of PRP injections or prolotherapy amongst our physical medicine rehab colleagues, sports medicine colleagues. At UC Davis, where I did my fellowship, we were constantly asked to teach them how to do ultrasound-guided injections, in which we found ways to be busy. They bought an ultrasound machine and often attempted to do injections. So like Dr. Campbell was speaking about, it's something that we want to grab early and often, otherwise it will slip away from us. We're going to talk about tendon injections. Again, tendons in the elbow are similar to tendons in the shoulder. We'll talk about the biceps and triceps tendon and also elbow bursae. So an elbow joint, most common reason to access the elbow joint is going to be an arthrogram or a steroid injection. Reasons that we do an arthrogram is usually for an MRI. We're looking for a foreign body, a cartilage lesion, tearing of the medial or lateral collateral ligaments, looking for full thickness tears or undersurface tearing of those ligaments. On MRI, we're going to use in the elbow joints about 6 to 10 cc's total volume, depending upon the size of the patient and what it looks like on ultrasound as far as the posterior recess. I typically use a 25 gauge 1.5 inch needle. It's a very superficial joint, easy to access. As in most cases with MRI, we use 1 in 200 mixture of gadolinium. This is the mixture that I use in the elbow that gives us that 1 in 200 concentration. CT is another way of doing an arthrogram. If the patient has a pacemaker, we can look for cartilage lesions or full thickness tearing or undersurface tearing of those medial or lateral collateral ligaments. And then probably most common would be a therapeutic injection. Now I use a 5 cc syringe initially loaded with 1% lidocaine to verify that I'm in the joint. I look at the posterior recess to make sure that there's fluid filling that joint, and then I go ahead and inject my 20 to 40 milligrams of Kenalog. And I add in there a 1 to 2 cc solution of 1% lidocaine. And I do that because you can often have a steroid flare because of the Kenalog, because it is a crystalline material. And at David Grant, we're in the process of switching over from Kenalog for the same reason that Dr. Campbell mentioned earlier. This is what he was talking about. This was originally discovered in 2004, and it was 2 patients, a 16-year-old and an 18-year-old, who had continuous infusion bupivacaine pumps after arthroscopy. One had a labral repair, the other a subacromial decompression. It was originally thought only to be secondary to the high volume amount of bupivacaine they inject at 4 milliliters per hour for a period of 46 to 72 hours for pain relief. This is the 18-year-old. You can see the normal shoulder pre-op. 5 months later, you see joint space narrowing, maybe some subchondral sclerosis. And then on the 8-month follow-up radiograph, you see that there actually is some chondral lysis of bone. You see the osteoarthritis is developing in this 18-year-old female. Constance Shu is the one that's doing real-time work on this, and they have shown that actually a single injection of bupivacaine 0.5% has been damaging to chondrocytes. You see this micrograph showing normal chondrocyte after saline, and then 50% loss of chondrocytes after a single intra-articular injection of bupivacaine in lab animals. Other studies have shown that 1% lidocaine and 2% xylocaine, or 2% lidocaine, have been less damaging, more equivalent to what saline would be. Also, ropivacaine, as Dr. Campbell mentioned, is shown to be the same as 1% lidocaine. But he also said it's about 3 times more expensive than bupivacaine. So what we do at DGMC is we're using 1% lidocaine for now. We'll probably switch to ropivacaine when we determine what we're going to do with our steroid that we use. But we see what we lose on bupivacaine and why we use bupivacaine. It's one of the longer acting local anesthetics. It gives you up to 6 hours of relief. It can get the patient home and in bed feeling great and get to sleep and enjoy the procedure, whereas with lidocaine, we're only getting up to 2 hours of pain relief. And we can bridge that with ropivacaine, although it doesn't give us up to that 6 hours of relief. So those are the reasons that we're moving away from bupivacaine. Now let's talk about these procedures in the elbow. First off, an arthrogram. Now I choose the radiocapitellar joint for access for an arthrogram, for MRI or steroid injection. Positioning of the patient, you can see the patient is prone, just like you would do a fluoroscopic guided arthrogram of the elbow. This is an ultrasound image showing the capitellum of the distal humerus and the radial head, and you see the radial collateral ligament and then the joint space. So we're shooting for that joint space. I use a linear transducer. We have it at Travis, a hockey stick, or a hockey stick transducer, which is a 12 megahertz linear transducer. It's small. It allows us to get the needle right next to the probe. We position our ultrasound probe parallel to the radius, and then we move proximally to see the transition between the two cortical surfaces. And then the probe is centered on the joint line. Now, I insert that needle in short axis to the joint because the joint, the radiocapitellar joint, is a more vertically oriented joint. It's going to be difficult to come in a longitudinal fashion, although you could get under that radial collateral ligament if you wanted to. Now, my probe is more angulated than I want it to be because I was paying attention to what was going on with the camera, making sure the patient's face wasn't in the picture, making sure the tech was taking the proper picture. So this should actually be more parallel with the radius, but you can see how my needle is inserted in long axis in short axis to the ultrasound probe. And you see the radial head, the capitellum, and then the needle tip is the echogenic focus within the joint space. That's after a very small test injection of 1% lidocaine to verify I'm in the joint. Another way of verifying that you're in the joint is looking for the microbubbles that are in all your solutions that you inject. No matter how many times you flick that syringe, there are going to be microbubbles in that solution. So you're going to have some echogenic foci within it, and that we can use to verify that we're in the joint. So those are microbubbles. And here's an image of the posterior fossa. So we're longitudinal to the triceps tendon, posterior superior to the olecranon process, and you see it in the posterior recess, this hypoechoic fluid collection, which is in the joint space, and verification of that we're in the right space. Again, I use 6 to 10 cc's. This is generally the amount of steroid I use, unless it's a smaller, older lady. I'll use 20, maybe 30 milligrams of Kenalog. Again, this will change, although for the lecture, I just put Kenalog. And I happen to do this patient on the fluoro table for this lecture, and this is the fluoroscopic image, a single spot image, showing the needle in the joint space. Here's the anterior recess, and here's the posterior recess of that elbow joint. So we can look at this on the cadaver, and you'll see that this is actually, I feel it's easier than doing it under fluoro because you see it real time. Okay, so the posterior approach I also use, but I use this in cases where our orthopedists think that there's a joint infection, or there's a rheumatologist that wants to aspirate the joint, the patient has gout or some crystalline deposition disease, or they have rheumatoid arthritis, but this is a little different. I think it may be infected. So I use this approach to aspirate the joint, positioning the patient, similar to what we did on the arthrogram. Although I may elevate the patient's arm under the elbow with some rolled towels, just so I get some space between the probe and the table. Or you can sit, if they're a younger patient who's not going to pass out because of the needle, you can sit with the arm on the Mayo stand. And I have had patients pass out from just having the needle go into this seizure-like activity as they go vasovagal. And that would be bad if they were sitting on the Mayo, with the Mayo stand up, similar to what you would do with a thoracentesis. Again, I use a linear. That rarely do I ever use a curved, other than in exams that are limited by body habitus. So we'll keep our probe parallel to the shaft of the humerus on the distal and posterior aspect, just superior to the olecranon. We look for the transition between the echogenic surface of the humerus and then the olecranon. And then we center the probe on that joint line. And we can insert the needle either in short axis or in long axis. I prefer long axis. Here's the humerus in this image. The arrow is similar to the needle path that we use to get into the posterior fossa. You see that posterior fat pad. So this is what I use for aspiration of the joint. Now for aspiration, you're going to use a larger gauge needle. Typically I use an 18 gauge needle because you're not sure how thick that synovial fluid is going to be. Typically a 20 or a 60 cc syringe, depending on the size of the effusion, some tubing just for to make it look good, and then some non-bacteriostatic saline may be needed as well. Oftentimes we're not able to get fluid from the joint, but they're still concerned for infection, so you want to flush it with some non-bacteriostatic saline, and that's critical. Also, you want to avoid putting lidocaine into the joint because it is bacteriostatic, and you will ruin the test that you're trying to help your orthopedist with. Again, the olecranon recess, posterior recess, ideal because you avoid the neurovascular bundle. Here's some images. Humerus, like we saw in the previous, olecranon fossa. This is a long ultrasound image. Here's a short axis. Here's that olecranon fossa or trans or short trans axis. You see that fat pad. Now here's a joint effusion of that same long axis image, distal humerus. You see this is actually more of a flexed elbow because you don't see the olecranon. You see this joint effusion. And then here's the short axis or trans image showing the same displacement of the fat pad. Same thing we see on plane radiograph. It would be really easy to take a needle and just put it right there. And it's really a nice way to do a joint aspiration. Now, elbow tendons, this is why our sports medicine colleagues love to do these, because they feel like they can treat common extensor, common flexor, medial and lateral epicondylitis. They stay away from the triceps or biceps tendon usually. It's usually these medial and lateral epicondylitis that they mess with. Typically, the treatment for this is going to be conservative. Rest, ice, Motrin. Corticosteroid injection is a secondary measure, and then surgical debridement and fixation with cerclage wires may be another treatment as well if they fail all these conservative measures. Now, Dr. Campbell talked about intratendinous injections of steroid, weakening the tendon, and it can cause rupture. A lot of that literature comes from really modern age ultrasound machines and probes where physical therapists, those were doing it by palpation, orthopedists, where they were doing intratendinous injections unknowingly and multiple times, and it ruptured the tendon. Where this is an example of an intratendinous injection, which I try to avoid on a steroid injection. I'll show you a case where I actually do intratendinous injection. We want to take a more shallow course along the axis of the medial or lateral, or the common flexor or common extensor tendon. This is the lateral epicondyle or common extensor tendon. So you have lateral epicondylitis, needle tracked along the axis of the tendon, avoiding the substance, and injecting steroid and lidocaine along the course of the tendon. Again, there's our needle, and then as we draw back, I tend to inject along the course of the tendon to splay that out. Now, what you want to avoid doing is injecting a large amount of Kenalog in this region. We talked about the different types of steroid. You need to research that and make sure that you're not injecting a large amount of subcutaneous steroid, because this can cause local atrophy and changes in pigmentation. Those are more common side effects than tendon rupture from steroid injection. So this is a review done of shoulder and elbow tendon injection of steroid. Now, this has showed that the main risk factors were skin modification, and so pigmentation changes and atrophy. Rupture was not seen as commonly. Only a few cases of ruptures This just reviewed all randomized controlled studies of steroid injections of the shoulder and elbow. One thing that they did note was that steroid, although it gives you a short-term relief, a year from now, there was no benefit over conservative management, and the patient still returned with pain and chronic medial or lateral epicondylitis. Now, there's hope for this, and what we're doing at Travis now is we're doing platelet-rich plasma injections for these types of things. Most commonly in the medial and lateral epicondyle, Achilles tendon, plantar fascia. I'm going to show you a hamstring tendon case that we did recently. So there have been some very small studies. This is not common practice. These are mostly case reports. It's still being defined as far as the success level, the amount that you inject, the technique that you use. But in this 15 patients randomized controlled trial, they usually use the visual analog scale to determine success, whether the patient is having improved pain or not. At the 6 month after a single injection, you had an 81% improvement. And then at the 25-month, you had a 93% improvement. And what this is showing is that with PRP, you're getting a progressive improvement of healing rather than an initial relief of inflammation and then a weakening of the tendon, secondary to steroid, and then re-injury. So this may be a way to produce continued healing. And then another double-blind randomized controlled study showing, again, progressive improvement. This is an example of a distal biceps tendon. You see this hypoechoic, very thick distal biceps tendon at the radial tuberosity. Put color Doppler on that. You see the hyperemia that has resulted from the inflammation. This is a trans image showing the same thing. Now, this is done with the patient in the supine position, with the hand supine as well. You can easily get a 25 gauge needle into this. I use a 5 cc syringe. Now with the steroid injection, again, I go along the course of the tendon from proximal to distal. Then I retract my needle along the course of the tendon just to splay the steroid out to decrease the inflammation along the course of the tendinopathy. Now with PRP, that's one time where we now do intratendinous injection. The goal is to get a platelet-rich plasma. We take the patient's blood, we spin it down, we take the platelets and the growth factors essentially in the middle layer, and we inject that into the area of tendinosis. So it's an autologous injection of the patient's own platelets and growth factors. So we take the needle, we maintain the same access site, we retract the needle, we lay a tract of platelet-rich plasma along the tendon. We leave the same access hole, we redirect the needle, we do another tract, again, another tract, and then again, another tract along the course of the tendinosis, laying out the platelet-rich plasma in the tendon. Now, the purpose of that is to create healing, to promote growth factor, to recruit healing cells that then causes healing of this tendon. So in the triceps tendon is a tendon. We're going to use a similar technique. This is a triceps tendon, long axis. You see the fibers of the tendon, very echogenic. This hypoechoic area, some of which is tendinopathy, some of which is shadowing from these calcifications. So you have calcific tendinopathy in the triceps tendon. We're going to use a similar technique. I have seen platelet-rich plasma injections described in the triceps tendon. I have an orthopedist that wants me to do this for him, platelet-rich plasma injection in the triceps tendon. I haven't yet done it. I've done steroid injections, and we're doing the same thing. We're going right along the superficial margin of the triceps tendon, laying the steroid on the surface, avoiding intratendinous injection. And then we pull that back along the course. So the bursa of the elbow, there are actually some antecubital bursae. That consists of the bicipital radial bursa and the intraosseous bursa, which often communicate. So here's the bicipital radial bursa between the biceps tendon and the radius, and then the intraosseous bursa, which the name implies, between the radius and the ulna. This can be inflamed. It can be confused for bicipital tendinopathy. If it is, that's great for us. Our orthopedist frustrated with the long wait with MRI. It's 40 days now at Travis before we're getting our new magnet. Hopefully that'll decrease as we add another magnet, the wait time. But they'll often call us in the afternoon as our procedure time. They'll send up their patient. We'll do a quick ultrasound. If there's something we see that we can intervene on, we intervene on it right there. That has done not only improve the relationship between the orthopedist and us in MSK radiology, but also keeps the business in radiology and keeps them from pursuing their own ultrasound machine and also sending them to physical therapy for injection or to physical medicine rehab or to an outside facility. We're now realizing that our primary care physicians are sending these patients out for platelet-rich plasma injections, and now we are now going to capture those patients and be able to do these on our own. So here's a case of a bursa in the elbow. Here's the bicipital radial bursa and long axis to the humeral shaft. There's the biceps tendon coming over the top. You see the brachial artery. Very important that you put flow on this image so that you avoid the brachial artery and do not aspirate the brachial artery instead of the bicipital radial bursa. You see the synovitis within this bursa, and then needle track. That's the beauty of ultrasound. You can avoid the vessels, you avoid the neurovascular bundle. You come in long axis on a trans image on that bursa. Really, with ultrasound, it's going to be up to you, the position that the patient's in, the direction of the probe, the direction of the needle. It's really up to you, and that's the beauty of ultrasound. So in this case, we just do a simple 20 milligram injection, aspirate then a 20 milligram injection of Kenalog into this bursa. It's a small space, so we want to keep a small dose of steroid into it to avoid the steroid flare that does occur. Here's a corresponding MR image. You see the brachial artery, the neurovascular bundle. Here's the biceps tendon, and then the bicipital radial bursa. You see interposing between the radius and the biceps tendon. You see how if we come from a radial approach, how easy that is to get steroid in that. The patients will be forever grateful, and they really appreciate the relief of pain. Again, we saw a case of olecranon bursitis. Similar procedure. We take a 20 to 25 gauge needle with 1.5 inches. Very simple procedure. You see fluid, you put the needle into it. You get good at placing needles under ultrasound by thyroid biopsies. I don't know if you know Camara Thompson, but she supervised my very first thyroid biopsy when I was a first year, when she was a first year staff. And then you just go from there. You go to PICC lines, learn how to get it in short axis, you get it in long axis, and then pretty much anything under ultrasound, you can put a needle in that place. All right.